Good morning. I'll call to order the Green Mountain Care Board's hearing of May 28th. We have three presentations today on hospital quality, which is an important issue for us to understand a little more deeply and for the state to have knowledge of. So I thank everyone for coming and further educating us on this topic. Before I turn to Ms. Barabee, I'll move to approve the minutes from May 21st, 2025.
Second.
All in favor, say aye.
Aye.
Aye. Aye.
Aye. The minutes are approved. Ms. Barabee, please introduce yourself and today's speakers, and we look forward to the presentations.
Great. So I'll start with some overview slides. My name is Elena Barabee. I'm the Director of Health Systems Policy at the board. And we have been thinking about quality for some time, and I think everything gets very busy and it's been a while. So I'm hoping this can be a start to a series of conversations and thinking about how we can really emphasize quality in our work. So again, today we're going to hear from, I'll just do a brief overview to kick us off. Then we have Jen Campbell from the Vermont Department of Health, who's going to walk us through some hospital report card data. Kathy Roche is joining us from New York. This is their hospital system, and they have a quality department there that supports their hospitals, kind of akin to our VPQHC, and she'll help us understand Vermont CMS star ratings. And she did a deeper dive there on some of their results. And then we have with us also Lisa Sutter from Yale, the Center for Outcomes Research. And so she'll talk to us more about kind of the quality measurement, and she's the one that's on the team that actually developed some of these CMS measures. And I hope we can have a discussion and, of course, public comment. So quickly, what is quality and why does it matter? Quality is defined by the National Academies of Science, Engineering, and Medicine as the degree to which health services for individuals and populations increase the likelihood of a desired health outcome and are consistent with current professional knowledge. So it's changing, kind of the more we learn about what produces better health outcomes, what is quality and what's considered quality is changing. So I think that's important to note. And then high quality in healthcare is really important because it leads to better patient outcomes. So, some examples of this, and this is certainly not everything or comprehensive, but, reductions in medical errors are, currently there are between estimated 200,000 or 400,000 deaths annually due to medical errors. That's just deaths. That's not other kinds of injury or disease. There are fewer avoidable deaths when we have higher quality care. The U.S. is actually, ranks, I think, last and has been ranking last on avoidable deaths. And this is increasing and actually disproportionately affecting rural areas. So we're worse off than our urban counterparts. And then finally, quality is also quite related, as we've heard in some of our discussions with other folks like Peter Pronovost, associated with costs. So lower quality outcomes can be quite costly. There's this study by Shrink and a team of other researchers from 2019 that estimates the waste in the US healthcare system to be between $205 and $345 billion associated with kind of poor quality and quality of care. So it's not insignificant. This is not a new topic area. So this was a report put out by the Institute of Medicine in early 2000s and has been a focus of researchers and of government and of, patients want high quality care. There's been attention to how we should be thinking about quality and measuring quality and where we should be looking at quality. The Institute of Medicine in this report, which if you haven't read it is worth looking at, identified 6 kind of domains of quality, kind of safety of care, effective care, patient-centered care, timely care, efficient care, and equitable care. So this means that when patients go and receive healthcare services, we want to make sure that they avoid harm when receiving those services. We want to make sure that it's effective, that we're not just providing people services that they don't need, that it's patient-centered, so it's in a way that they need it, that it's timely, so they don't have to wait excessive amounts of time while they're getting sicker before they receive the care that they need, We want to make sure that it's efficient, so they're not getting it at a super high cost or using up services that couldn't be allocated elsewhere. We also want to make sure that care is equitably distributed, so that not only a select few have access to high quality care. So how do we achieve better healthcare? This is kind of to anchor you on kind of how some of these measures are developed. There's this framework called structure, process, and outcome that's been around for a couple of decades now. It's a Donabedian framework created in 1982. So the structure is really describing the context. So the healthcare facilities, personnel, organizational characteristics, payment that kind of enable quality to happen. I think you've heard kind of from the 80s and the rationing of care, when you live under a capitated model, there's some incentives to withhold care. And so there were some concerns about what that meant for quality outcomes. So, that's one example. Having we talked about culture is incredibly important. Having your organizational leadership pay attention to quality and value quality is important to enable the processes through which quality happens and people can actually get high quality care. So if you don't pay attention to it and you don't prioritize it or invest in it, it's likely not going to happen and affect the outcomes of care. So this is just kind of keep in mind that this, we're talking about measures, we're talking about quality and how it happens, but it's really about a system that works together to achieve those outcomes. And again, quality is not just about what happens at the organization, but also about how the organizations in the broader system work together. So it's really about delivering quality across a continuum of care. So it requires, when we say right care, right time, right place, it's, our patients getting the care they need in the primary and preventative settings, as opposed to, showing up in the emergency room and seeing, getting care that they need, but maybe not where they need it and by the people that they need it. And so just keep in mind that organizations are responsible for making sure that how they are delivering care is, high quality and effective, but also patients being sorted through a system may affect kind of the quality of care that they experience. So I just wanted to highlight a couple considerations as you're going to hear from our next speakers. So they're, talk about some of these things, but, there's differences between quality and quality measurement. So what we can measure, what we can identify is often observable, we hope it's observable, but quality itself sometimes more intangible. So trying to figure out what we measure and how we measure it can sometimes be a challenge. The purpose of measurement can be multiple. So it's about driving improvement. It can be about holding organizations and folks accountable for the care they deliver. It could also be about payment. It could be about, I think I didn't have it here explicitly, but transparency and kind of enabling patients to make better decisions about where they receive care and from whom. What is measurable versus what's important. We have to, CMS has this initiative called Measures That Matter. So we want to make sure that when we're highlighting particular measures or a set of measures that we think that they're actually going to impact patients' care and outcomes in a way that is important. And then accuracy, precision, and timeliness of measurement. This will come up, but it's hard. There are a lot of moving pieces. This is, it's not always easy to know and to gather data as we go. And oftentimes we rely on claims data, which, is lagged, but these are things that we have to think about when we're looking at measures and interpreting measures. And then burden of measurement. So it would be great if we could have someone kind of, getting into the weeds and reporting but we also need to recognize that with that additional reporting comes an additional administrative burden. So trying to find the right balance. And then possible unintended consequences of measurement. I think there was a robust shift to pay per performance. And actually what you saw is kind of some perverse incentives set up because we articulated we were really interested in a certain set of measures. And then by directing your attention, you kind of sometimes miss the bigger picture. And so these are just theoretical concepts. I think you'll hear more from our speakers, and I hope that we can kind of return to these over the next series of discussions and kind of dig into this further. But in summary, we require measurement in order to improve quality. There's no single perfect measure. We have to think about, what's important and what the trade-offs are when we're selecting measures. But I definitely think it's important. We shouldn't throw the baby out with the bathwater, but it's going to take some work to get it right. So I will turn it over. So next we'll hear from Jen Campbell from the Department of Health. And then we'll hear from Kathy Roche from the Healthcare Association of New York State, and then Lisa Sutter from the Yale School of Medicine. And so I just want you to think about, how do we make sure we are paying attention to the right measures and what structures must be in place to support a high quality healthcare system in Vermont? And I don't think we'll have all the pieces to answer that today, but I hope that this will at least take us in the step forward. So I will stop sharing, and Jen, if you want to pop your slides up, and if that's possible, I can. Great. Thank you. And maybe you can introduce yourself and a little bit of your background before you dive in.
Good morning. Hopefully folks can see my slides. My name is Jen Campbell. I am a public health analyst for the Vermont Department of Health. I'm here to discuss the hospital report cards. I've been in a position since 2023, and prior to that, I worked on some COVID stuff, and long before that, I was a social worker. So lived a couple of different professional lives before I landed here. All right, so a little bit of history for the report card for folks. It comes from Act 53, which was passed by the legislature in 2003. Originally, the Department of Banking. Is my screen going weird? I apologize. Can folks see my slides all right?
No,
No.
they were doing weird, as you
They
said.
were doing weird something. Sorry about that. I'll try again here.
That looks good.
Okay. We'll hope it stays working well. Technology is great when it plays nicely. All right. So originally, the Department of Banking, Insurance, Securities, and Healthcare Administration was in charge. They later became the Department of Financial Regulation. And during the 2013-2014 legislative session, some of their positions transferred to the Green Mountain Care Board, and the Department of Financial Regulation transferred the report card position to the Department of Health. So Act 53 was an act relating to hospital and healthcare system accountability, capital spending, and annual budgets. One of the requirements of Act 53 is that hospitals publish annual hospital community reports containing information about quality, financial health, cost for services, and other hospital characteristics. The purpose of the report card is to develop tools and resources to assist consumers and payers with making healthcare decisions by providing accessible, useful information, comparing hospital costs and performance. So what's included in legislation are measures of quality, including process and performance measures that are valid, reliable, and useful, measures of patient safety that are valid, reliable, and useful, including comparisons to appropriate industry benchmarks for safety, measures of hospital-acquired infections that are valid, reliable, and useful, including comparisons to appropriate industry benchmarks, valid, reliable, and useful information on nurse staffing, including comparisons to appropriate industry benchmarks for safety. This may include system-centered measures such as skill mix, nursing hours per patient day, and other system-centered measures for which reliable industry benchmarks become available. Measures of hospitals' financial health, including comparisons to appropriate national benchmarks for efficient operation and fiscal health. A summary of hospitals' budget, including revenue by source, the 1-year and 4-year capital expenditure plans, depreciation schedule for existing facilities, and quantification of cost shifting to private payers. And data that provides valid, reliable, and useful, efficient information for payers and the public for comparison of charges for higher volume healthcare services. Number 8 is what hospitals are required to publish on their websites, and is the Community Health Needs Assessment, which is conducted every 3 years, its strategic plan and annual progress report, how to file a complaint, information about hospital governance, and a link to the hospital report card website. So the 2 measures I was going to look at today for folks are readmission rates and mortality rates. Readmission rates come from, or the data we use comes from CMS, and it's updated annually in July. These rates show how many patients go back to the hospital within 30 days of their original stay for either heart attack, heart failure, pneumonia, or a hospital-wide admission. The rates are risk adjusted and a lower score is better. In our annual publication, we look at readmission rates kind of like the slide on the screen, where it's just sort of the shot for the past year. My understanding was that folks were more interested in trend data for today, so I've recompiled the slides to look at a couple of years over time. So we're going to start by looking at readmission for treatment after a heart attack. So looking at this, the most important thing is that going back to 2019, no hospitals have readmission rates after treatment for a heart attack that are any different than the national rate. Nobody was any better, nobody was any worse. The majority of hospitals were the same, but there were a large number of hospitals that had too few readmissions for the data to be calculated and have rates compiled. Looking at readmission for treatment after heart failure, similar information. From 2019 through 2023, no hospitals had any fewer or worse ratings. In 2024, there was one hospital that had a higher readmission rate than the national rate, but the majority of the hospitals, again, had readmission rates that were the same as the national rate. Looking at readmission after treatment for pneumonia, I can't get a true trend because there was no data for 2020 and CMS suppressed the data for 2022, so I didn't have new data there, but figured I would throw up what we had so folks could still take a look at it. And looking at this data, the majority of the hospitals, again, have rates that are the same as the national rate, and sorry, no hospital had a higher readmission rate than the national rate. And looking at readmission after hospital-wide treatment, the majority of hospitals, again, were the same as the national rate. 2 hospitals did have readmission rates that were higher than the national rate in 2022, but this decreased by 1 in 2023, and by 2024, no hospitals had any readmission rates that were higher than the national rate. Looking at mortality rates, this data also comes from CMS and is updated annually in July. These rates show how many patients die within 30 days of their original stay for a heart attack, heart failure, and pneumonia. Rates are risk adjusted and a lower score is better. So looking at mortality after treatment for a heart attack, there again were a considerable number of hospitals where the numbers were just too small for rates to be compiled. But importantly, no hospitals had mortality rates after treatment for a heart attack that were any different than the national rate from 2019 through 2024. Mortality rates for heart failure. The majority of hospitals, again, had mortality rates that were the same as the national rate. One hospital did have a mortality rate that was higher than the national rate in 2023 and 2024, and it was the same hospital for both years.
Hey, Jennifer, can I interrupt for a second?
Sure.
Can you go back to 13, and then I just want to make sure I'm understanding the graphs. Okay, so 13 is the mortality rates across hospitals. So at the top, you have the national result. So we have a mortality rate of 12.6, which is a number of, what is that? The percentage of patients who die within 30 days after having a heart attack at a particular hospital. Am I reading that right? Okay.
Yes.
And so then CVMC in the 2024 report card had 12% of its patients die within 30 days after receiving care for a heart attack, slightly below the national average. I'm reading that correct?
Correct.
Okay. And then, all right. And then the next slide you're showing is the change over time. What is the 9 and the 5? What are those lines representing?
Those are representing the number of hospitals in Vermont. So that top line, the red one, is the number of hospitals in Vermont that had rates that were the same as the national rate. So in 2019, 9 hospitals had the same as the national rate, 2021, 8, 2022, 8, and then back up to 9 for 2023 and 2024.
And then so take 2019. In 2019, 9 hospitals had a rate that was consistent with national average, and 5 had a rate that was what?
5 had a rate that could not be calculated because the numbers were too small.
Got it. Okay. And then do the next slide.
So for heart failure, in 2019, 13 were consistent with the national rate. One was too small, one was worse, and there were none that were better than the national rate.
Okay, and so the one that's worse, that's the blue number?
Correct.
Okay, so in 2019, 2023, and 2024, one hospital in Vermont had worse data than the national average. Got it. Okay.
Correct.
And is that the same hospital in each of those 3 years, or is that a different hospital?
For 2023 and 2024, it was the same. I would have to double check for 2019.
Okay, all right. Thank you.
Sure. All right. And looking at information for pneumonia, similar to the readmission rates, I can't get a true trend because there was no data for 2020 and again for 2022. But the majority of hospitals had rates consistent with the national rate. There was one hospital that had a mortality rate that was lower than the national rate for both 2023 and 2024, and that was the same hospital. And there was also one hospital that had a mortality rate that was higher than the national rate for 2023 and 2024, and that was also the same hospital. And that's all I have for my data. Do folks have questions or wait till after? All right.
I can. Sorry, okay, we're trying to figure out who's unmuting here. Thank you so much. I have a couple of questions actually about that data. One is, I noticed that you described the hospitals but didn't name the hospitals. Is there a reason for that? I'm assuming it's on the website.
It is on the website. I can certainly. Oh, sorry. Go ahead.
Yeah, could you share with us?
Yes. So let me just go back to the hospitals. So for readmission for heart failure, the hospital that in 2024 had a rating that was worse than the national rating was CVMC. For readmission rates for hospital-wide treatment, in 2022, both CVMC and UVMMC had rates that were higher than the national rate. And in 2023, White River Junction VA Hospital had a rate that was higher than the national rate.
Okay, thank you. And my other question, actually, I happened to be on the hospital report cards maybe about a week or two ago, poking around trying to understand it. And one of the pieces of information that I found particularly interesting up there was the serious reportable events. That's on that same website. And I was struck by the growth in serious reportable events over time. Back in 2013, I think there were 34 serious reportable events, and these are, events where there's some clinical intervention that causes serious harm, death, or serious injury that could have been prevented. So there were 34 of those serious reportable events in 2013, and by 2022, it was up to 124, and slightly down in 2023, it was 111. And I'm just wondering if you could talk a little bit about that and what, how that data is collected, and any information you have about where they're occurring, or if there's any trends in where they're occurring. And, the 3x growth in serious reportable events is troubling, and I would love to learn a little bit more about that if you could share anything, if you have any information. If you don't, you have to get back to us, that's great too, but I saw that and I thought, oh, what's going on there?
Sure. So unfortunately, I don't have information to share about that data. It's not what I compile. However, Margaret Robinson, who does put that report together, is going to be leading a webinar last weekend in June. I can get that date to folks, actually going over that report and that information.
Wonderful. Okay, I appreciate that very much. Thank you.
Any other questions on the data, or we can turn it over to Kathy? Okay, thank you. Thanks, Jen. Kathy, welcome.
Thank you, and good morning, everyone. I really appreciate the opportunity to join you this morning. My name is Kathy Rao. I'm the Vice President of Quality at Haney's. I am a nurse by background, and I've been working in healthcare quality, patient safety, and related roles for over 20 years. I really appreciate the opportunity to talk a little bit about the CMS overall hospital star ratings. If I don't mention, though, that Dr. Sutter is a expert in this, I would that would be inappropriate. So I do want to acknowledge Dr. Sutter in the work that you and your colleagues do on this. And really, just to kind of give you a little bit of the why Haney's has, provided this, this presentation, is, the star ratings is a little complicated for the audience in which it's intended, right? So going back to what we had heard Elena mention, she talked about crossing the quality chasm, and to me, To Err is Human was really the report that catalyzed so much of the work that we do in quality and patient safety. And in those reports is really, how to err is human really said we need to focus on, this industry and making care safer. And to me, crossing the quality chasm was a bit of the map to help us get there. And in those reports, what they recognized was that consumers were not well informed about what was happening as far as the delivery of care. CMS, I think, made an attempt to provide data to the public through Care Compare. I don't know if any of you have ever navigated it over the years, but it wasn't really easy to understand whether something was good or not. I don't know, Dr. Sutter, if you agree with that, but it wasn't very intuitive. And so for what it's worth, I think the intent of star ratings is to try to make it a little bit easier for consumers to understand or to be able to look and to see where the rating is. Most are familiar with that star rating system. So I just wanted to give you a little bit of the background about, where this comes from, what the intent is, who the audience really has been intended for star ratings. I think all of those pieces are somewhat helpful in this conversation. We have found, even though, many of our members and our quality leaders are, been a part of quality reporting programs and efforts for many, many years, we needed to take some time and really break it down so we understood it better. And so we could respond to those opportunities. So let's see, just trying to get into the slideshow, so I apologize. There we go. Okay. And then Elena, if you could just let me know if you're seeing the actual full slide, that would be helpful.
Yes, there it is.
Wonderful, thank you. Okay. So really what I am hoping to do today is just to go through the star ratings methodology, talk a little bit about where it's been, where it is today, and then, talk about the methodology itself as far as what are the 7 steps for a star rating to be created. And then I have some data that's specific to Vermont. So we'll, walk through and talk through some of that as well. And then, certainly happy to answer any questions at the end. So the star ratings methodology goes back to 2016. That's when it was initially released. And I do think that it was really well intended to try to make this data available more frequently, and to make it as real time and as, meaningful as possible. I do think, though, just getting it off the ground was a little bit more challenging to get that done. So over the last, I would say, 10 years, it really has gone through some changes to really make the methodology a little bit stronger and the data a little bit more clear. I know when we were looking back at the 2017 methodology, it was really challenging for us sometimes to explain to quality leaders, what convergence means and Windsorization. And so I know that, there's been a lot of work done to try to make it a little bit more cleaner, the methodology for all of us to be able to understand how that calculation works and how hospitals have resulted with their star ratings. Most recently, though, we saw in 2021 that there was a shift from the statistical modeling to an equal weighting approach for domain scores. Again, I think that goes back to some of the advocacy on the methodology that I mentioned, and also to help stratify the K-means based on the number of reported domains. And I'll talk a little bit more about K-means and some of that. And then just the last piece was they had consolidated There were some domains that were at 4%, and that also occurred in 2021. There has been nothing more so far, so that's where we are in the methodology. And as I said, I think, CMS has really been staying committed to trying to make this, a meaningful, approach. I know that they've been making the effort to make the data updates and the measure, everything more consistent. They made a commitment to annually, which I think that's worked out somewhat better. And again, I think that just looking at the comparability of star ratings between hospitals, we can appreciate that with peer grouping and other things they've done. Again, it seems all to be directionally correct, and we appreciate all that effort. So as I had mentioned, it is a 7-step process. So we start off, or CMS starts off, with selecting the measures. It's important for me just to mention that the measures come from the inpatient and the outpatient quality reporting programs. So it's a blend of those measures that they draw from. And currently there are 46 measures in the July 2024 report, and that's what I'm going to be focusing on and talking about. I know that they're getting, CMS is getting ready to release the updated, but for this conversation, it'll be focused on that July report that was released in 2024. And then I'll talk a little bit more about group measuring. That's the second step. There's also a step in calculating the group score. And then the fourth step is generating a summary score. After that, there is the applying the reporting thresholds, and then applying the peer grouping. And then the last step will be calculating the star rating. So I'll walk you through. I won't spend too much time, but just want to make sure everybody has a sense of how star ratings are calculated. So I think what's helpful to just kind of cover quickly is one of the challenges I think, had to be for how do you take all of these different measures, right? So we have percentages, we have the amount of time for a patient to be seen in the ED and admitted to the unit, right? There were all these different, pieces of information that CMS had to come up with a way to standardize it. And so the approach is called Z-scoring. And again, it's a way for them that there can be these different types of scoring information, and it can be put in as a common language. It also helps too, because then there, could be a situation where a quality measure could have two directions, where either lower is better, like think about our readmissions and our mortality, or where higher may be better. And, we think about things about healthcare workers being vaccinated. So again, to try to help communicate this information in a consistent way, Z-scoring is applied to those measures. And then as far as our measure groups go, where we are today is there are the 5, and mortality, safety of care, readmissions, and patient experience has a weighting of 22%. And then timely and effective care has 12%. And timely effective care is really, again, where those 4% domains were rolled up into that one category. And then as we can see that there are, a different number of measures in each one of these domains, and with the largest being in timely and effective care, and the smallest being in mortality. And I'll look and we'll talk more about those. So then the next step is to be able to then score the calculation for the group, right? And so CMS is takes those measures and they average them using the Z-scores within each group. I think what I always want to remind folks is that individual measure weights will differ depending on the number of measures in each group, and that is reported by the provider. So again, if there are, as I just shared, a certain number of measures in a domain, but you may not have enough cases, or you may not be performing a certain procedure, let's say, that's included in one of those domains, the weighting will be shifted based on those measures not having enough cases or not being applicable to the calculation. And then there's the summary score calculation, where CMS uses a weighted average of the group scores to determine a summary metric for each provider. I walked through and had already said which are the 22%, and where we have a 12% weighted domain. And it's a way for This methodology is a way to facilitate combining them into that final overall score. And so using the simple average of measure group scores, the distributions and interpretations of measure group scores may differ. So again, standardizing the group scores ensures that there are similar values that represent similar relative performance. It's also important to know that there are some reporting requirements to be able to be eligible for overall hospital star rating. Hospitals must have 3 or more measures in 3 measure groups, and one of the measure groups must be mortality or safety of care. We do have some critical access hospitals who voluntarily suppress their data, and so they are not included. I know that CMS has really been moving towards making sure that critical access hospitals are included, but they can voluntarily suppress. So just wanted to mention that as well. And then to translate each hospital's summary score to a rating between 1 and 5 stars, this is where CMS uses the K-means clustering algorithm. And what K-means clustering is a way for each peer group, right, is to separate them out so that the hospitals are only compared to similar facilities. The analysis is a standard method for creating a pre-specified number of categories so that observations in each category are closer to their category mean than others. And so again, this is a screenshot from Haney's, and it's part of our report card or our report. I think it's helpful when we look at the data or we use this approach. What you can appreciate again is that on the left, providers with 5 domains on the left, you can appreciate where the the gradient is between 1 star and 2 star, 3, 4, and 5. And what we find sometimes is that hospitals may be, let's say, at the 2-star level, but they may be right on that cusp or that threshold. So by us using these visuals to help analyze the data, it's been able to give our members more clarity than what the CMS reports have been able to provide, so they understand kind of where they are in that process or in that progression. So I wanted just to take a moment to talk a little bit about the July 2024 performance periods. I know that there was the extraordinary circumstances exception period. That was something that was applied during the COVID pandemic. It was a period of time where CMS had said, no quality reporting was required. They had then kind of re-implemented it, or brought it back up. I think it was within 6 months after that determination was made. Some hospitals were able to continue to have exemptions, awarded to them through CMS, but just in the thinking of where is the data for that specific, exception period, we're watching over time, right, that the data is becoming closer to where after that period of time. So in this performance or in this report, 89% of the data that was collected was after the June 30th, 2020 period. So again, it just is helpful for folks to kind of put that into some context when you're, thinking about the report and the period. And then what we do at Haney's as well is we break out in a reference guide just so it's a little bit easier visually to appreciate. So here's the COVID-19 exclusion period. It's this tan line that rides right down the middle or, down each of the domains. And then what you can appreciate is for like safety of care, that some of the data goes back into 2019 for hip knee complications, where other data points are more, more real time, let's say into that 2022, 2023 period. So I think that's the other part that's also helpful is when you're looking at the data to understand that some of the outcome measures go back into a 3-year period, and that others that again, like patient experience and timely and effective care, we can look at data points that are a little bit closer to where we are today. And then again, I think that when CMS was preparing this report to be released, they wanted to make sure that they were able to maximize the number of eligible hospitals. There was a opportunity, or they really wanted to look at how they could minimize that impact to that exception period that I just mentioned. And they were also wanting to make sure that if there was any measure updates or recalculations, that they were able to accommodate. And there was one for this particular report, which was related to PSI 90. And then I just wanted to mention that in the upcoming report, we know that there are a couple of measures that will have been retired. It's also helpful when we're thinking through at the quality level, just for us to kind of be aware of what we'll be seeing in the upcoming reports. It helps us just to kind of, determine where we want to be, again, focusing our efforts or know what's coming up. So for example, safe use of opioids is will be a new measure that will be included in the upcoming report. What I think is significant about it is it's an electronic clinical quality measure. So it's the first one that will be included. And, it's a different approach for data collection. So again, I just think that's a bit of a signal for quality leaders to understand that those measures are now progressing into public reporting and likely the performance programs in the future. So just to take a few minutes and look at Vermont star ratings, your distribution, what we did, our economics team did, is they looked at what the national star ratings distribution was for this report. And then they also then calculated how it looks for Vermont. And what you can appreciate is, there's a bell on both. And where the ratings for 2024, lived for Vermont is, on the left-hand side, red is obviously your 1 stars, and on the right are your 5 stars. So again, you have 1 hospital that received a 1 star, 5 that were receiving the 5-star rating, and then everybody else is in between here of your 2s, 3s, and 4s. And then we wanted to get a sense of what did that look like over multiple years. And, here's in 2022, what it looked like nationally and where Vermont hospitals were. You can appreciate that in 2022 and 2023 reports, there were no hospitals that had received a 1 star. It is in 2024 where there was the 1 hospital that I just mentioned. And then again, you can appreciate that there was a decrease in your 5 stars beginning in 2023. And then we saw another drop in 2024's report. So just to give you a bit of a sense of where Vermont hospitals are compared to the national distribution, here were a couple of different graphs for you. And then what we wanted to do is to look at the scores by domain. And so just to reorient you, the purple means high performance, and then the brown is more of a indicator or is, reflective of low performance. So where there is strength in Vermont is in timely and effective care, in patient experience and readmissions, where there's opportunity in mortality and in safety of care. We also wanted to get a sense of Vermont's performance by hospital. And so we de-identified the hospitals, and what you will see on the left-hand side is that they are ranked by 5, 4, 3, 2, 1, and then there were a few hospitals that had no rating. And then if you look across, again, the color coding is purple is high, and then the browns are on the lower. You can see where some hospitals excel in different domains, compared to others. I mean, you look at patient experience, and many of your hospitals are certainly in that higher performance gradient. Just for, what it's worth, New York doesn't look anything like that. New York hospitals overall are very low nationally in patient experience. So clearly patient experience is a strength in your state. Timely and effective care, we also see a good amount of purple, and it also in your readmission scores. And of course, there's, some opportunities, but I think that's what we anticipate, right? We are working on quality, but there are some things that, again, have strength and others that we continue to focus on. So we broke out then the measures, for each one of the domains. And so in mortality, we wanted just again to try to get a sense of which of those measures, where was there the strength, right? And where there was the most opportunity. And what you can appreciate is that your coronary artery bypass 30-day mortality rate, we see that it's a high performing measure where the PSI 4, which is a composite for surgical complications. I'm sorry, it's the patient safety indicator 4, which is for surgical complications. Let me just clarify that. And that's where there's some opportunity. I just want to take a moment and talk about the PSIs because it will also pop up in another domain. The patient safety indicators, that's what PSI stands for, were developed by AHRQ. Truly, they weren't designed, or at least they weren't initially, the intention was for quality reporting, but they have been a part of the quality reporting measures for quite a while now. And they are claims-based measures. They are, I think, a little bit of a different measure for some, hospitals to wrap their arms around, in that it's not something that I think most hospitals initially were drilling down on and looking at all of those cases. So I think over time we have been watching more and more hospitals really use those cases for peer review, M&M, and some other, ways of really understanding where there's that opportunity for improvement. So I just wanted to call it out. I think it's very common. We've seen it in New York hospitals, Vermont. Clearly there's an opportunity, and some others where the PSIs usually are an area of opportunity. And then on readmissions, it's the 30-day readmission for coronary artery bypass. That again, there's high performance, and then there's opportunity on the lower end where there is your EDAC, so your hospital return days for heart failure patients, your admissions for patients receiving outpatient chemotherapy, those who are visiting the hospital after outpatient surgery, and then also visits for patients who are receiving outpatient chemotherapy. So again, looking at those would probably be some things to drill down and to look to see where, the opportunities are, and to also try to, I feel like, again, this is all helpful information, but to me, that's some of the outcome measures, they're the signals. It's really looking at your real-time data to make sure that those opportunities that were flagged here remain, something that's a current, a current opportunity for improvement. As I mentioned, you have a lot of strength in patient experience. Cleanliness and quietness of the hospital environment was on the lower side. I think, quite honestly, that's very, very common nationally. A lot of hospitals are just older, and there's a lot of other reasons why we see that scored on the lower end. And then looking at your safety scores, your MRSA is at the top for performance, and then where there's opportunity is in some of the infections, hospital-acquired infections. So Claudia, C. diff are certainly two surgical site infections, colons and abdominal hysterectomies. And then the other PSI that's a part of the star ratings measures is the patient safety indicator 90 composite measure. And so underneath that composite are several other measures. So sepsis, falls, pressure injuries, just to name a few. So there's another layer that has to be peeled back to really analyze that data.
Kathy, could I ask one quick question on Dave Merman on the Green Mountain Care Board? Are all of these measures that we're looking at here been adjusted into a normal distribution, so that that we're comparing what we're comparing against the mean of the distribution, essentially? So say like
yes,
these are all comparative measures against averages, I guess is what I'm asking.
Yes.
Okay, thank you.
Yes. Okay, and then timely and effective care. We see that there is, again, strength in many of these measures. I won't go through all of them, but again, you can appreciate that there is some opportunity for improvement. And, when I look at where those are, you look at ED arrival to ED discharge, departure, ED left without being seen. I don't know that that would be very surprising, just knowing that there has been, between workforce shortages and other challenges, those tend to be common opportunities across the board nationally. A lot of it has to do, again, with the flow of your patients as well as other factors. So again, not diminishing there's opportunity, but just we know that there are other factors that certainly affect the ED's flow. And then sepsis and sepsis shock, is an opportunity. Again, nationally, I think we see that as a common area. And then there's brain scan within 45 minutes of arrival of stroke, and then your elective delivery prior to 39 weeks of gestation. So when we also wanted just to kind of pull all of that apart a little bit to say where is the highest scoring, so just to kind of give you the takeaways. Again, there's strength in your coronary artery bypass, readmission and mortality measures, MSRA, bacteremia, and then your patient experience related to discharge information, and then COVID vaccination among healthcare providers. On the other side, again, when I look at it, I can appreciate that, again, there may be some opportunity looking at those hospital-acquired infections, mortality, stroke. And again, to me, there's a bit of a relationship when you're looking at the timeliness of care, right? We had said that 45-minute brain scan, and then I see the mortality for stroke. To me, I would, probably want to look at that a little bit closer. And then that PSI-4 that we talked about. And then this is just a visual that our economics finance team put together just to give you a sense of the distribution. It might be a little hard to see, but you can see that the one-star hospital is kind of here, where the 2 stars, the 2-star hospitals that were ranked, one's over in this, kind of range. These 2 are here. So again, kind of if you split the difference, this one's a little bit closer to 1, and these are a little bit closer to 3. So that's really, again, what we use this graph for, is just to try to give a sense of where folks are in that scoring range. And then you can see 3s, 4s, and then there is a 5 that's on here as well.
Sorry, Kathy, what's the vertical axis represent? So you have them kind of, some are on the horizontal axis closer to the left, which I am taking to read as lower within that distribution of 1. So our 1-star hospital is quite a bit below the average of the 1-star hospitals. What's the vertical axis represent?
Well, it's interesting, and thank you for asking. I should have said, actually, it's somewhat random where they land in the column. So it's just more about the placement as far as near each other or being further away from, each score. It's not so much being on the lower or the upper. It's just, that was just how the graphic had kind of laid the stars out. So I apologize. I should have clarified that.
Yeah, got it. Thank you.
Yeah. Are there any other questions?
Go ahead.
Here, maybe Dave Herman, can I just pop in first? Can we go back to that slide one more time then? Just because I had a similar. So is the horizontal axis then related to the relative ranking within the star rating? So the 5-star hospital is just made it into 5, or is this random?
Yes, so it's right. So it's more that these hospitals, right? So the 5-star is just inside of that 5 threshold, right? Okay. And then these 2 here are just inside the 4, where this one is more midpoint. Okay. That's really what this slide was trying to help, to more look at it from that perspective versus being low or higher in each of the columns, if that makes sense.
That does. Thank you. And then
okay,
one of the things we look like we're doing really well in our CABG related outcomes, coronary artery bypass graft surgery outcomes. Those 2 ratings looked really strong. They're done at one hospital in the state, and I think a fairly low volume, and a program that's expanding from my understanding. Do we know, are these CABG scores acuity related or patient complexity related? Are they adjusted for a selection of who gets a CABG at that hospital?
Well, there is risk adjustment to the measures. That's about probably the most I could offer off the top of my head, but maybe Dr. Sutter can give you more of the detail.
Sure. Both the mortality and readmission measures are risk adjusted for claims. I think this reporting cycle, the claims are using what are known as condition categories, but they're a way for grouping thousands of ICD-10 codes into clinically related groups. And then there's like, I don't know, 40 or 50 of those groups used to risk adjust the mortality and readmission measures. So they're accounting for things like age, presence of comorbidities, not the number of comorbidities, but the types of comorbidities. Measures, most of the measures also include frailty indices, and I don't think this uses some frailty indices, but I think the CMS is going to be updating to have more detailed frailty information that even use like durable medical equipment coming in the future. But I don't know that this data has that yet.
Go ahead.
Could I ask a follow-up question about that, please, Dr. Sutter? And Kathy, thank you for walking us through this so well. This is, I'm Tom Walsh, I'm a board member. I want to make sure that I understand the risk adjustment process with these measures, because we hear pretty regularly that Vermonters are relatively healthy. And if that were the case, and that was taken into account with the statistical methods, and our readmission and mortality data are worsening, that seems more alarming than if our patients were sicker. Am I reading that? Am I thinking about that correctly, or am I misinterpreting or reading too much into this?
No, I agree. Actually, Kathy, do you mind if I share a slide? It might help
by all
for
means.
this conversation.
No, go ahead. Let me stop sharing. Sorry, my apologies. There you go.
There we go. Okay, now, hopefully you're seeing a slide that says trade-off risk adjustment versus none.
Yes.
Okay, great. So I think the important thing when we think about risk adjustment is to recognize that risk adjustment is trying to define what's expected. So if Vermonters are healthier than the average American, you're exactly right, that worsening clinical outcomes on these measures would suggest that care is truly getting worse. The question now is, are Vermonters still as healthy as they were 5 years ago? And that's a question that you guys might be able to answer. So one of the things you can do, and I can take a little bit more time when we go over risk adjustment, but the idea behind risk adjustment is you're trying to define what you expect the outcome to be based on the case mix of the patients at a hospital or a surgical center or whatever entity. And then you look and see what the actual outcome rate is. So for this diagram, you have two hospitals, they have the same number of patients. Hospital A has fewer severely sick patients than Hospital B. Hospital A, because they have healthier patients, maybe they're in Vermont, we would only predict 3 deaths, but they actually have 5 deaths. Whereas Hospital B, we would predict 15 deaths because their patients are sicker, but they actually only had 10 deaths. If you just looked at observed outcomes, 5 per 100 or whatever the number of patients are versus 10, you would think Hospital A has the better care. But because you risk adjust, we know that Hospital B actually has fewer events than are predicted for that hospital. So they're performing better than expected, whereas hospital A is performing worse than expected. And star ratings is hard to look at because it's a conglomeration of a lot of measures, but when you go on to hospital or care compare, or you look at your hospital specific reports. So I don't know how many of you guys are actually pulling down and looking at your hospital specific reports from Medicare, but you all have them. And there are inboxes to answer questions around how to interpret these hospital specific reports. But each hospital specific report literally lists every patient from your hospital that's included in the CABG readmission measure. It gives you the state averages, it gives you the national averages, it lists risk adjustment factors. So you can actually dive in and see a lot more information. It can also help you understand if they're not being readmitted to your hospital, they're being readmitted to another hospital. I'm sure you guys have a lot of centralization at your major medical centers, and then patients distribute home to their local, more far-flung location. And if they're being readmitted, they're being readmitted to maybe their local hospital. And so these reports, because Medicare has all of that data and consolidates it, all that information's in your hospital-specific reports. And it is not uncommon that hospitals don't download their reports. And then even if they download them, they're not looking at them. So it's a piece of information that's really useful, but not everybody digs into it. I'm happy to continue on risk adjustment. I'm happy to flip back to the beginning of my talk. Whatever you guys want to do, I'm here to serve your needs.
We could ask a few more questions to Kathy.
Right.
Can I just ask a few questions just real quick, and then I'll pass off to on slide 12 in Kathy's slides. That's the slide where you have different hospitals that have different number of measures that they have sufficient data to report get compared to themselves, in a sense, right? And so I guess my question on that is, can you compare a hospital that has 3 domains with a hospital that has 5 domains? Because the hospital that has 3 domains is being compared to other hospitals with 3 domains, and a hospital that has 5 domains is being compared to other hospitals that have 5 domains.
I think I'll try to answer what I think your question is, but I just going back to, I think that part of the challenge when STARS was originally released was that there wasn't, the peer grouping, right? So it was really hard, I think, sometimes for consumers to appreciate that a hospital wasn't, a hospital isn't being, they wanted to level the playing field, I guess is a better way to say it, right? Like, so I'll, just for what it's worth, I'm in a rural area. I have 2 hospitals that are nearby. One is a smaller hospital. They are in the 3 domain, and they have a very low number of measures that just put them in for that eligibility, where the other, is larger, and they are in 5 domains. So I guess, my point is, I think it was intentional that CMS had broken them out into these peer groupings to try to make it a little clearer for consumers to be able to compare like to like, as far as us doing an analysis to look at, the hospitals across the domains. I don't know. I would think that's something we could do, but I don't know if that's answering your question. I'm really sorry.
And I'll just jump in that the peer groupings, exactly as you said, Kathy, are intended to reduce unfair comparisons. We know that peer groups correspond to hospital differences like size, bed volume, case and service mixes. 5 measure peer group hospitals are more likely to be larger hospitals, teaching hospitals, DISH payment eligible, non-critical access, non-safety net.
So I guess the question is, can you compare a pneumonia readmission rate at a critical access hospital with a large academic medical center, because, or some other, say, how about a patient safety component, or just the star rating, because they're being compared to a different group to determine where they sit on this, on what's they're being compared within a different z-score distribution, I guess, right?
So they're not being compared with a different z-scores distribution. The z-scores are calculated on national data. Their domain scores across their patient safety, readmission, mortality, those comparisons are to peer hospitals. Just like in the readmission reduction program, hospitals are stratified by their percentage of dual eligible Medicaid, Medicare patients and compared, payment is assigned based on your performance on the readmission measures to a peer group that have a similar proportion of dual eligible patients, figuring that readmissions are probably impacted by factors that dual eligibility may be an indirect measure of social determinants of health.
Okay. One other question I had on the cause being able to suppress their data. What are some reasons why a CAW would want to suppress that data? I would assume if it's unfavorable, they would want to suppress it and then thus not be star rated. Are there other reasons why a CAW would choose to do that?
I think that would be probably the most likely reason that they would make that decision.
Okay. And then just in general, looking at the Vermont hospitals, it really looks like our star scores are really lifted up by our patient experience domain and then pulled down by our kind of safety domains. Is that sort of what your look at that data would be?
Well, safety, so I'll see if I can, so when I looked at, so if you go to slide 20, right, by domain, safety of care is on the lower end of those 5 domains. And when we talked about safety of care, when I, looked at we pulled out each of the measures, what you appreciate is, the highest performing is the bacteremia. And then there were 2 others that were on the high performance side. And then there were 2, 4, 5 that were on, where there's opportunity. So yes, I would say your strength is certainly in your patient experience. And for that time period and looking at those measures, certainly those are, different areas that I would drill down to and to see where you are today, comparatively speaking.
Thanks.
I'll just note from my view of your reports from this talk, your outpatient data, your outpatient measures are, and a lot of your return to hospital measures, you're doing quite well on. So that's in the readmission domain, but also some of the outpatient imaging and other things. And your hospital-acquired infections tend to not be doing as well. The other thing I would say is for stroke mortality was also stroke mortality and brain imaging on presentation timeliness of brain imaging. For stroke mortality, that measure, I'm pretty sure now includes the NIH stroke severity scale in the risk adjustment. So one of the things you want to be really careful about is making sure that you're collecting that data and you're coding it appropriately. That's all, those are new codes in the last several years. And if your hospitals aren't adopting them, you may be not getting enough credit for the severity of the stroke on presentation. Because if there isn't data, the data assumes patients are healthier. So making sure that hospitals are collecting the NIH stroke severity scale and coding it appropriately in the ICD-10 codes will be an important check on your stroke mortality rates.
Thanks.
Kathy, if you wouldn't mind, can you just pull up slide 21? This is Jessica Holmes, I'm one of the board members.
Sure. Sorry, my apologies. Hold on. I have to share first. Always the share.
And while we're doing that after, we might want to switch over to Lisa so we can make sure we get her presentation in.
It's all good, Elena. As long as people are getting what they need out of a conversation, I can adjust. And Kathy's duplicated a lot of, I was talking about stars and, she used the same graphic I have. She talked about the COVID impact. So there's a lot of slides that I don't even need to cover.
Are you able to see slide 21?
I'm not seeing it, but.
Oh, no. Let me try it again.
I can just ask my question. It was the slide where you broke down the hospitals by the domains, and it was, and I guess I'm struggling in the same way that I've struggled with the last presentation, and that, one of the arguments that's made about the star ratings is it's supposed to help consumers and help us understand which hospitals may have different quality. And I was struck by the fact that you shielded the names of the hospitals. Hospital 1, Hospital 2. I mean, why, if this is public data, I guess I'm just wondering why we wouldn't want to be more transparent about the differences across hospitals. So I'm just curious about that.
Oh, well, to be honest, and just transparent, the analysis that I shared with you was something that I presented to the Vermont Program for Quality in Healthcare earlier this year as an opportunity to help, make sure that all quality leaders were up to speed on the ratings. So it was really part of my presentation to them that I had de-identified. To your point, the data is publicly reported. So I would think that the Vermont program would be the right group to ask for the listing. That's, kind of just why. It was more because of that audience and the intention of, or the focus of the conversation, that it was de-identified, if that makes sense.
Oh, okay. Yeah, no, that's helpful. Hopefully we can get the de-identified data. I think it's important for everybody to understand. And it would be, what I found interesting was about the domains, and I wish I had them, up, the slide was up, but I would love to see those trends over time within each of those domains a little bit, to Dave's question, to understand, is it the mortality and safety that's, declining over time? I have noticed, I did pull actually the 2022 star ratings and comparing them to today, and 7 of our hospitals have declined significantly, at least dropping more than 1 star, some of them 2 and 3 stars over this time period. So I do think we have to uncover what's happening. But let me just ask another quick question, and maybe I think, Dr. Suter, I think this might also be a question for you, but one of the struggles I've had, because I've spent a fair amount of time on Care Compare over the years, and because of our small size of our hospitals, most of them critical access hospitals, everything is NA, not everything. Obviously, there's enough here to generate star ratings, but there's so much that's not applicable. There's not enough volume to answer the questions. And so I do struggle with how useful in some cases these star ratings are. And I also struggle with an alternative to what we can use in Vermont that actually will help patients, guide them towards higher quality care. And it was troubling to me. I always assumed that those hospitals that didn't have star ratings, of which I think it's Grace Cottage, Mount Putney, and Springfield, those are the 3 hospitals that back in 2022 didn't have star ratings. Today they don't have star ratings. I always assumed it was a volume issue, although Springfield should have enough volume. If it's a voluntary suppressing of data, that's actually a little bit more troubling to me. So I would love, and maybe we can switch over at some point, but I just would love to know, what do we do? How do we assess quality across more dimensions when we've got NA for so many of these features? Can we look over time? Is there another way? I just would love to hear some experts tell us how we can do that.
So there are lots of reasons why measures aren't reported or star ratings aren't reported. Obviously, volume is one, and it's one of the more common reasons that hospitals aren't reporting. You don't have publicly reported stars or measure results. The fact that critical access hospitals can suppress is, it's a constraint of the federal system that allows critical access hospitals that protection. I think that if you're within the healthcare system, you're within the hospital system, getting access to your hospital specific reports is absolutely the fastest and most effective way to uncover that information. And, you know, we could, I think, if you're within, I don't know whether they would release this information, but you might be able to ask in the inbox on, say, you know, the readmission, CMS's readmission measure inbox, did this hospital download their health, you know, hospital specific reports for the last 3 years? And you can actually find out, we might be able to ask and see, because we keep track of who downloads and who doesn't. So it might be possible to actually find out whether or not those hospitals are even bothering to look at their results. At least the last time I talked to our team about this, which was a couple of years ago, you know, a fraction of hospitals were actually, like, you know, 40% of hospitals were downloading their specific reports. That may be higher now with, you know, growing penalties, but that would be one recommendation, is finding out if they're actually looking at their data, and if they're not, asking them why, and pushing from that perspective.
So Dr. Sutter, I'd like to just jump on that for a moment, because you're right. And I think we see that very much with, you know, our quality leaders. It's not something that they immediately download and analyze. I think some of them, you know, feel that they're using real-time data and their own dashboards, so they don't lean in as much. But I think probably the bigger opportunity is, I don't think that they all know how to interpret the data. To be honest with you, I think the Excel report is a little hard to really be able to walk away, you know, and that's why I think our star ratings analysis has been something that New York hospitals have asked us to come and provide, because we give it color, right? We break it down, we help to kind of, you know, make it, I think, a little bit more visually, you know, intuitive, right? Where you're doing well and so on. So just for what it's worth, I think that we have done some workshops with our quality leaders to make sure that they are downloading those reports and to help them navigate the CMS ones, but then we wrap around them with these as well. So just a couple of comments there.
Thank you.
Great. This is all jotting notes down as we go. So lots of ideas for Vermont. I appreciate that. Lisa, should we turn it over to you for the slides that we haven't covered?
Sure.
And round us out. Thank you.
So hopefully you're looking at a quality measurement slide. And so just a little background, I'm an internist and a rheumatologist. I practice within an academic medical center and within our local VA. I've been involved in quality measure development for more than 15 years. And with the Center for Outcomes Research and Evaluation, we've either developed or stewarded over 70 measures across 16 federal programs and payment models for the Centers for Medicare and Medicaid Services, or CMS, and the Innovation Center, or CMMI. And I direct multiple contracts with CMS to build these measures and maintain and implement these measures for use in federal payment. I'm not a CMS representative, so that's my caveat. My other caveat is, as a measure developer, and for doing this, you know, for more than a decade, there are no perfect measures. Every measure is a balance, and understanding, and, you know, it's my goal as a developer to articulate a lot of the trade-offs so that users understand the limitations of the measures. So ideally, a good measure makes inappropriate variation in care transparent. It helps providers understand and improve care. That's why you guys are on the call today. It helps patients choose where to get healthcare when they have the option or opportunity to choose. And increasingly, it helps payers identify high utilizers, quality and cost outliers, and create incentives to improve care. And we know that there's a national push towards value-based care payment. So from your perspective, you need responsive, timely metrics to inform quality improvement. Oftentimes, these look like process measures, which Elena described. Process measures are very useful. They provide a roadmap for how to get to ideal improved outcomes, but we know that changing the process doesn't always yield better outcomes. So as Kathy was talking about, supplementing your real-time information with, broad outcome information is a helpful counter. We've been talking a lot about how patients have difficulty understanding complex methodology and comparisons, and so they prefer simpler rating systems, but rating systems can hide methodologic flaws and biases. And, I probably won't spend a lot more time talking about cert ratings, but you can see that there's a lot of challenges that go into trying to consolidate that complexity into a simple score. And then payers, they need accurate, reliable data, both for benefits, that's where quality measures come in, and costs to guide value-based payment. This means that oftentimes they're using older data and longer periods of data that allow for less responsiveness, but that gives them adequate data accuracy and case volume so that they're having reliable estimates of hospital or other performance to avoid assigning payment on something that may be varying. As I noted before, good measures balance the inevitable trade-offs. And when we design measures, we really focus on how the measure is going to be used, because the use helps us design better. We weigh the competing needs, and we try to minimize unintended consequences. So when we design for a specific application, we prioritize different components. Those components include the denominator, or the group of patients or cohort of patients that you're measuring. The outcome, I build mostly outcome measures, but the numerator, if you're looking at a process measure, it's, did you give beta blockers for AMI? If you're looking at an outcome, it's the return to hospital or 30-day readmission rate, or the 30-day mortality rate. The period of measurement, Medicare uses a 3-year period of measurement. That's a very long period of time. So in any given year, you've got 2 years of overlap. So seeing changes is hard to do with the claims-based measures that they use, whereas the hospital-acquired infections, those data are, those turnover, they have shorter periods and they turn over faster, so you'll see change faster. We have to attribute to the right entity. So hospitals, it's easier, but for clinicians, it may be hard. Who's the primary clinician taking care of, an individual? And as we talked about, we have to account for differences in case mix so that we're not penalizing hospitals or providers that are taking care of more complex or medically severe patients. And the primary, among the unintended consequences, many include deprioritization of unmeasured outcomes. This is a big concern where people say, if we're focused only on whatever readmission, then maybe our mortality or our hospital-acquired infection rates are going to go up. Certainly decreased access, disparities in care, and sometimes inappropriate behavior, which we talked about a little bit earlier with sort of early measurement, or sort of driving people to make decisions that weren't in the best interest of patients. So I'm just going to talk through a couple examples. So CMS has a voluntary measure for patients undergoing hip and elective primary hip and knee arthroplasty or replacement that uses patient-reported outcome, or PRO data. And this makes sense because elective hip and knee replacement are intended to reduce pain and improve function. They don't change survival. It's purely patient pain and function. And so you would imagine that patient-reported outcomes are the primary way to capture whether or not those procedures are effective. But despite that, surgeons were in general not collecting this information systematically. And that has changed over time. A lot of the orthopedic professional societies support collection of patient-reported outcomes. This measure now incentivizes collection of patient-reported outcomes. But we have decades of care that don't integrate collecting patient-reported outcomes for these patients. And then you have a measure from CMS that comes along and says, okay, now you have to do this. And a lot of hospitals, a lot of providers are forcing that process without trying to incorporate it into the workflow. And that is one of the highest burden ways to incorporate patient-reported outcomes. You get a lot of low response rates, you get frustration, or you throw money at it. You know, you have a dedicated nurse calling up patients and hounding them to get responses to their surveys. Having worked with surgeons for many years on patient-reported outcomes in this area, the most successful for any patient-reported outcomes, but certainly in orthopedics, are the surgeons who use them at the point of care for shared decision-making with their patients. So their patients see how the patient-reported outcome data is being used for themselves. It helps them understand that they're going to see a change when they have the procedure. It helps the surgeon decide if they're recovering at the expected trajectory, and they have the highest rates of response. That said, patient-reported outcomes are always going to be burdensome. We know that we ask patients and providers to fill out tons of surveys. I'm sure you guys are frustrated just as your patients are, that more and more surveys are in and more is being asked of them. Just checking in for an appointment, you have long checklists of things, and collecting patient-reported outcome data only adds to this. So we do have to balance that. In this case, there really isn't any other way to meaningfully capture whether or not patients are having their pain reduced without asking them. But in other circumstances, it might make sense to use data or look at outcomes that don't require any sort of burden on the provider or the patient. And that's where the claims-based measures come in. CMS, has really tried to minimize burden on hospitals. So another trade-off other than burden versus granularity of data or detail of data is the timeliness of data and also the reliability of the estimates. So Medicare claims data can be changed and adjusted up to 1 year after submission. So Medicare has final action claims and non-final action claims, and they want to only use final action claims in their quality measures. So they give hospitals a year to correct their claims. That means that your data that you're being measured on is already a year old when those results are calculated. And because the Medicare uses 3 years of data, some of that data is 4 years old. So it's really not very timely. It's not very useful for looking at, the interventions that you guys are doing on the ground. And that's why a lot of hospitals choose not to download those hospital-specific reports and use them. They'd rather use their real-time data. But that information is still valuable. We talked about the fact that CMS only publicly reports results for hospitals with minimal case volumes, but they're still calculating results for those hospitals. So even if you're a critical access hospital and you choose not to publicly report, or if you're a low volume hospital and you don't have enough cases to report, you still get a hospital specific report. Reliability is also, in addition to just general case volume, reliability of the measure is impacted by the outcome rate. If you have a very rare outcome or a rare numerator event rate, it is harder to get robust reliability. And if you have very little performance variation, so if everybody looks the same, it's also, in some ways, everybody looks the same, so that's reliable. But from a statistical standpoint, reliability rates tend to be lower. We talked about risk adjustment. I'll just note that when it comes to certain aspects, when you when you create a risk model for a measure and you define the expected outcome for a group of patients based on, their clinical characteristics, their age, whether or not they have diabetes with complications, et cetera, you assign a probability of the outcome for that risk factor. If you put something like race into that risk model, you are assigning a predictive value based on your data. And if you have existing disparities, say, for example, Blacks have higher readmission rates in Vermont, that gets captured into the risk model, and therefore hospitals with higher percentages of Black patients will be expected to do worse. And it doesn't allow you to correct the problem. It actually makes those hospitals who have disparities look better. So in certain circumstances, it's appropriate to think about other approaches than risk adjustment, things like stratification or risk adjusting payment versus performance or stratifying payment. We're not going to talk about stars. So I'm happy to take questions.
Great, Lisa, this is Tom Walsh again. Your slide on risk adjustment, I wanted to ask a follow-up question from our conversation earlier where you were talking about illness severity. And some of the measures that you've discussed today have a 3-year window that's looked at. Some are shorter than that. I'd like to understand if we're seeing higher severity illness with a substantial change in a short period of time, can you tease out, or can we learn from somewhere to tease out whether that's due to an actual decline in the health of our population versus a change in the coding patterns used in our organizations? Because
Okay.
I'm familiar with some research about changing coding patterns, for example.
Yeah, so it's a great question, and you can look at the prevalence of different codes within your population in your hospital specific reports. But that doesn't answer your question as to whether or not coding is changing versus actual clinical health status is changing. When the first claims-based measures were developed, the measures, we had already had, cabbage claims-based measures sort of fail. So there was, skepticism that claims-based data could equal clinical data. And sure enough, if you try to make an administrative claim for, let's say, COPD, if you try to make it act like an FEV1, it's never going to do that. But if you let it just be its own data point and you aggregate that data at the patient level, those risk models perform just as well as clinical, models based on medical record abstraction. It still doesn't answer your question as to whether or not your patients are getting sicker. I do think you can certainly look at your coding patterns to see if your coding patterns have changed. And I will say that nationally, many hospitals have experienced worsening hospital-acquired infections post-pandemic. And a lot of this, I think, reflects the fact that our safety protocols are vulnerable to disruption. Admittedly, the pandemic was, an unprecedented disruption. But then the ongoing shortage of staff, I think, has continued to show vulnerabilities. So Vermont is not the only location that's seeing decrements in hospital-acquired condition those rates are going up at a lot of other institutions.
Thank you. A quick follow-up. Do you know of any research looking into what would be an expected amount of increase in severity if a population was declining? So, for example, if we see a big jump in risk, it's hard to imagine what happens in 1 year, particularly if the window that's being looked at is 3. So I'm just trying to educate myself about how to understand that a little bit better.
Yeah. So my instinct is for the star ratings is to, and maybe Kathy and, Haney's can help here, is to go back through the, the input into star ratings over time, right? So that right now, but there are certain things that you're performing, the state isn't performing well on. But to sort of drill down to understand how has your performance on stroke been over time, right? Is stroke mortality always been rotten, or is stroke mortality getting worse? And that kind of information may help you tease out a little bit where to focus and what is driving some of this. I think it is always important to recognize that, and there may be other things too, right? Like hospitals may have gone from one peer group to another because they're collecting more data and they're reporting on more quality measures. And if that's the case, they may have bumped into a group of hospitals that, have, higher case volumes or something like that. And so, maybe you're looking at being on the edge of that peer group. The other thing to recognize is anytime we're doing this kind of public reporting, we're drawing a hard line, and there is always blurriness. But something like star ratings, something like hospital readmission reduction program, you have to draw that hard line, right? There has to be a winner and a loser according to hospital readmission reduction program, right? There are hospitals that get money and there are hospitals that lose money. Now, the further you are from kind of expected in terms of your performance, the worse you perform, the greater your financial penalties. So there's some quantification to that. But, the fact that somebody's standardized risk ratio is, 0.9999 or 1.00001, are those hospitals really different? No, but one's going to lose money and one's going to gain money. So drawing that hard line is an inevitable part of this. And the question is, you saw how close, hospital percentages, those hospital performance was in stars. So next year could be worse unless you guys figure out what's pushing those, what's at the heart of the measures over time, and how are trends in measures changing over time.
Okay, thank you very much.
Any other questions for Lisa?
Maybe I can just ask one more quick one, which is I'm still trying to understand this cost suppression stuff to some degree. If costs do suppress their data, does the data not get into the analysis of their peer group?
No, the data is even if the data is not publicly reported, it's still included in all the calculations. So they're still part of, that cause data contributes to figuring out what the national average is. So that's all still happening in the background. The only, there are like extraordinary circumstances where sometimes, a hospital has something going on and CMS might withdraw that measure from calculation, but that's extraordinarily rare. And it usually has to do with, things like Katrina or, something like that. Yeah.
Okay. Thank you so much for coming to speak with us today, but I don't have any further questions. Thanks.
Total pleasure.
Very helpful.
This is a passion of mine. So anytime you want me to come back and bore you with quality measurement, I'm happy to do that.
I had
Looks good deal to me.
two quick questions. For the hospitals that suppress, they still get this data, right?
Yes, yes.
Okay.
If
And
they download it.
right, okay.
Yeah.
And can we download their data? You said we can. I can go on the website and download it myself for any hospital in Vermont today.
No, so
Yes.
you can
Oh.
download the public data, but
Right.
I don't know what the board has access to, but I could not go and get UVM Medical Center's data, their hospital specific report with all that patient information. That's confidentially provided to them through a secure portal.
I see.
But I can go to, that's why I put the Care Compare link up there. I could go and I could get all of their star ratings. The Care Compare shows me what their domain score is. It doesn't show me, I think, all the details of the measures underneath, but then I can go elsewhere in Care Compare and look at their measure results. It's just not neatly, I can only look at 3 hospitals at a time and compare 3 hospitals at a time on Care Compare. It is not from a state level or a hospital level standpoint, it's a very cumbersome website. It's not user-friendly, as Kathy noted.
The only thing I would offer is that there is the data.cms.gov
Yes.
website with all the data sets, and there is hospital data, but it's it's a little unwieldy. It would take somebody to come in and analyze it, but it is out there publicly.
Yeah, and so are the statistical packages that include the risk models. Those are all, they're not posted, but they're available by request. The challenge is, though, that you don't necessarily have all the national data, so you can't always reproduce CMS's results, but you can at least see what they're putting into the risk model.
Okay. And then the data in the STARS reports, does that overlap with Medicare's hospital-acquired condition reduction program and the financial penalties? It's the same data being used to administer that program?
For yes, the readmission measures in the readmission reduction program are the same readmission measures in STARS, although I think STARS has a broader, the readmission reduction program has a limited, you have to go through rulemaking to be included in the readmission reduction program. So not all of the measures that are in the readmission domain are included in HRP. So for example, there are measures called the EDAC measures, which are the excess days in acute care. Those are balancing measures to readmission. They also give you information around emergency department and observation stay visits, not just readmissions to the inpatient setting. Those are not in the readmission reduction program. So what's in STARS is more than what's in HRP, but the Venn diagrams overlap.
Got it. And then could you just give a short background on what is the CMS hospital value-based purchasing program?
Okay, so obviously the value-based purchasing program is a payment program that assigns inpatient facilities based on not only their performance on different measures, usually focused on things like complications of care or safety measures, but also how much they're changing. So the readmission reduction program looks only at a point in time. And each year you're assessed for where you are on the readmission measures. And if your standardized risk ratio is higher than 1, then you are worse than expected and you get penalized. The further from 1, the more you're penalized. The lower below 1, the more money you get. But HVBP doesn't look just at the year that you're in for the measure performance. It looks at both the measure performance at that point in time, as well as whether or not you've improved over time. So it's a more complicated program, and it means that anytime they change a measure, that measure has to be in use for multiple years so they can get a baseline in order to figure out if hospitals' performance have changed. The idea being is they want to not only reward hospitals for performing well, but for getting better over time.
If I could just add to that. So, the way that I think it's sometimes helpful too is it's a zero sum, right? So every hospital contributes a certain amount of money into the value-based purchasing pot, right? And so the opportunity is that you could perform well enough that you retain those dollars. Or if your performance is strong, right, or stronger, right, then you could earn additional dollars that maybe lower performing hospitals, unfortunately, are leaving in the pot. The challenge is that everybody is working really, really hard on all of those measures. So it is, quite honestly, it gets hard to keep, holding those dollars and to be gaining more over time. And that's part of the CMS responsibility, quite honestly, is to be evaluating those measures. When they start to get topped out, when they don't become meaningful, right? They have to make sure that if we're working in these pay for performance spaces, right, we're able to actually make, improvements. And just going back to the hospital acquired condition program, that's a real tough one because there's, to Dr. Sutter's point, there's always somebody who is going to be in that threshold. So you could have one CAUTI, one CLABSI, whatever, it is, and it might just not be placing you in the right part of that threshold. So the challenges, I think, with the pay for performance programs is they are modeled differently as far as, how are they calculated? Hospital readmissions is one way, value-based purchasing is another, and HAC is another. So making life a little challenging in the quality world, you're trying to keep focused on that. Then, of course, there's stars, and then there's the day-to-day business. So for what it's worth, it just is a little complicated at times.
It's super complicated. I think the takeaway points are almost all programs are budget neutral, meaning they don't want to put money into a program. They want one hospital to get money from another hospital that loses money. So that's almost universal. The other is shoot, I just left my brain. Sorry.
It's all right.
I lost that point. If I think about it, I'll put it in the chat.
I'm having that more and more, and my experience is 5 minutes later, right after I leave something, I remember. So just email us if you do. So on the HAC program, it's the penalty, the amount of penalty is greater dependent on where you are. So they fine or have a financial penalty, whatever the language is, for the bottom quartile of hospitals in the nation, right? And so if the threshold is 0.3 and you're 0.9 and you're, the 90th percentile or which way it goes, you're fined more than somebody that's closer to that trigger. Is that right?
Yes.
Okay. And
yeah, go ahead.
Oh, sorry.
No, go ahead.
Okay. And then that penalty, how is that assessed? Is that on, so a VBP is through your DRG reimbursements, right? How is it applied in the HAC program?
Kathy, is that something you can respond to? I'm not sure I know exactly how penalties are assigned in HAC off the top of my head.
Yeah, so for HAC, just to clarify, it is going to be the let's see, total HAC scores greater than the 75th percentile of all scores will receive a 1% payment reduction. And this is usually through your market basket adjustment.
Okay.
And I'll just say that the other thing that I remembered was a lot of the measures, particularly the readmission measures and the mortality and measures, are related to national performance. So even if you guys are getting better, if you're not getting better faster than the whole nation is getting better, you can still see worse performance. So that's not all measures are like that, but the mortality and readmission measures are impacted by the national rate because they're calculated using the national rate.
Yeah, it's kind of like Survivor, a little competitive setup they got here. I kind of like it, to be honest.
Yeah, and it's a big question. I mean, in the HRP, 50% of hospitals are going to get penalties because they drew that the way methodologically they drew it at the median. So no matter how good the United States gets, HRP is always going to be penalizing 50% of hospitals. The only goal you can do is get as close to one as possible, as close to sort of the national, what you expect your patient readmission rate to be, is as close as you can get to that to minimize any potential for penalties. There's never going to be a everybody wins kind of scenario.
Okay, and then my last question is, there's been some discussion lately and concern that Medicare is not paying Vermont as much as other states. And I'm sure any sort of program like this is a minor drop in the bucket. But is there a easily accessible place to see what the total costs to the state and Medicare reimbursements are over a period of time from penalties in these programs?
It's a great question. Kathy, do you know if that's?
I don't know if I've ever seen that made publicly available. It's a great question, but I don't know that I've ever seen it.
Yeah, I don't know how closely you guys are following what's going on in Vermont, but we're in a bit of a pickle, and maximizing Medicare would be a huge step for us. And I have no sense about the total dollars that these programs and these quality impacts can have. I suspect it's quite small, but I really just don't know.
I mean, okay. I have to assume someone within the healthcare system or the hospital system has that information because they're seeing those penalties. So, within your hospital, you should have that information, and presumably the leadership is looking at that, and that's a driving strategy for the hospital, because most hospitals are in challenging financial times. I mean, we're seeing tons of hospital closures and consolidations, and they're all financially based. So if hospitals aren't focusing on where the dollars are, I'd be surprised.
Yeah, sure they are. Okay, I have nothing else.
The only thing I would add is, and I'm not looking to sell, but our DataGen, which is an our for-profit analytic shop, if I'm not mistaken, I do think though that they do a financial calculation on reports. So if you're interested, I'm happy to follow up, and then I can always get back to Elena if there's anything there.
If you could, I mean, we're really trying to find places we can maximize Medicare revenue, and I don't know where to focus myself on that. But if this is any sort of opportunity that we can help promote and support, it's good to know. Yeah,
let me do that, and I can certainly circle back.
Okay, great. Well, thank you both very much, and Elena too. This was really enlightening. This is great. So thank you. I'm going to open up to public comment via raise the hand function. Sam.
Good afternoon. Now it's 12:10. Thank you all for the presentation. Sam Peisch with the Vermont Office of the Healthcare Advocate. I just had two questions that I think are probably best for Dr. Sutter, but of course, if there are others that want to chime in. One, I was wondering about the use of what you think about the use of shrinkage estimation for small hospitals. I mean, I've done a little bit of work in that area, so I'm just curious if you think that would help, or if there are limitations to that method for trying to get some quality estimation for the smaller hospitals to address the low sample size issue.
Shrinkage is used statistically, just for the rest of the group, under circumstances where there is less data. And the readmission and mortality measures that CMS reports uses a hierarchical modeling approach where it's essentially employs a shrinkage technique that if there is less data from a hospital, it assumes that hospital is an average performing hospital. Mm. So, which is why you rarely see hospitals as performance outliers on their measures, right? They're almost always no different than the national average on readmission and mortality measures. It is an appropriate statistical assumption. There have been a number of, the presidents of statistical societies put together a white paper on that approach and agreed that it was the appropriate approach for high stakes performance, value-based payment. The challenge is that it really, and there's a big concern that small hospitals have poor quality and therefore you may be missing poor quality. And, I think that is somewhat an existential question, right? Like, how much do you want to hold a hospital to really unstable results? And oftentimes when you're looking at small hospitals, those measure results, observed results, are going to be wildly unstable, particularly for things like AMI, or, they're probably not doing cabbages, but, the AMI mortality is low, a very, very low outcome rate. Hip knee complications, we're already talking about 2% or 3% complication rate. So these are really hard events to capture in small hospitals without sort of unstable and therefore invalid results. So yes, I support shrinkage from when you're talking about high stakes payment, but it doesn't necessarily help you from a consumer perspective of using a small hospital versus a large hospital.
Okay. And my other question is, I'm curious if you've done any comparisons of quality scores by state to other international comparisons. Because I think one thing, candidly, I struggle with comparing to national benchmarks, which I think we should do to know where we are, is the US, I think, as we all know, does not compare very favorably to other OECD countries in a lot of these quality metrics. So even if we're beating a national average, it might not be a national average that is something we want to aspire towards. So I'm curious about comparisons that you've done or how you would approach that question.
It's a great question. I confess the only real national data, other than obscure things in rheumatology that I pay attention to, the only real national data that I look at, that I've looked at in the past, is UK data. And in some ways, those are hard to compare because, particularly for things like surgical procedures, where you don't get you won't get certain procedures over certain ages, right? Like you won't get a cabbage or a aortic valve replacement if you're older than whatever 80 or something like that. There's just socialized medicine has some constraints that make sometimes it hard to compare. I know that our patient-reported outcomes after hip and knee replacement are, as good or better than in the UK, but I don't have a lot of other, one-to-one comparisons for the measures. It's a great question, though.
Thank you. Appreciate it.
Any other public comment? Great. Lisa and Kathy, thank you so much. And we will probably take you up on your offer to continue to help us. Quality is an area where we want to continue learning more. So thank you for being available to assist us.
Happy to do so. Thanks so much for letting me participate today. It was a great conversation.
Yes, thank you for the invitation. I appreciate the opportunity.
Thank you. Is there any old or new business for the board? Okay, then I will move to adjourn.
Second.
All in favor, say aye.
Aye.
All right.
Aye.